I'm proposing that our secretariat with the legal team to immediately come up with amendments to the SHA Law. Because once that is law, one, it has to be embedded in law. What is the time frame that they're actually meant to pay? What date are they actually meant to pay? Two, what are the penalties? So we come up and draft amendments that are going to be something that is going to be very, very shaky. The issues that are there is delay in payment. So we have to make it very clear that the same way they're saying that by 7th, by 9th, that there's a cutoff. Our proposal will be that within this period of time, the following 9th or the following 10th or the following 15th, they should have already paid to the facilities. Two, it also has to be very clear in that particular legislation. Because you see, they have a whole thing, the one for the digital health. But there's nowhere that talks about what happens when there's no connectivity. So we have to amend that law to include, I don't want to go to that example, but what is going to happen one day if they decide to shut down the internet? So we need to come up with an amendment to include as well that what happens in the event that for whatever reason there is no internet.
On the issue of locking out our staff from SHA claims by 9th. Today is 5th. I can guarantee you by 9th we will not have gotten our disbursement. Our disbursement will come after 9th. By the time we remit, it will be around 17th. We will not remit less money for SHA simply because the date passed. But for the time when they have not been able to get our remittance, our people will be locked out. It is as if we have a date with when we have to get sick. If there's a way we can tell our people don't get sick during this period, then that will be easy. But diseases are there all the time. So why this discrimination? There's national government employees. Are they also being locked out? Of course not. So what arrangement they make? This is blunted discrimination, Chair, without even trying to hide anything.
And we would like to have a distinction between emergency services and referral services. A lot of time, the referral services that happen in counties are in twofold, where the doctors have realized that they cannot be able to manage to treat a patient, and they want to refer a patient to maybe a level 7 or level 6 hospital, and that happens frequently. In my county, we refer patients to Eldred MTRH. Also, on the other hand, elective referral, where the patient's caregivers feel that they want to go to another hospital because in their opinion, their patient is not getting the care that they want.
And right now what is happening, because at those level of care we are not providing maternity services, we are basically going back to where we are. So skilled delivery basically will drop. Mothers will not go to those facilities because they know where I used to deliver. If I don't deliver to the next facility that is near me, I rather deliver at home. So then that means skilled delivery will basically reduce, and we have already reports on that. The gazetted benefit package also limits maternity services to SHIV, which cannot be used in level 2 facilities. As a result, these facilities have missed out on at least Kenya shilling 2.6 billion as reimbursement from delivery. These primary healthcare facilities are supposed to be getting 10,000 Kenya shillings for every delivery, unlike NHIF, where they used to get 2,500. So as a result of missing out, as a result of the directives, cumulatively, these facilities can be able to miss out around 2.6 billion for only deliveries, because mothers now have to go to the higher level to deliver.
For example, excluding level 2 and 3 out of maternity is actually one of the worst thing which is actually doing. from the Linda Mama, as you said. For counties in rural, the rural counties, in the northern Kenya for that matter, in fact, we invested 70% of our health budget on level 2s and 3s because of the distance. For example, Mandera is about 260,000 square kilometers. I mean, 26,000 square kilometers.
Health financing in counties. You realize, Your Excellencies, as a result of withdrawal of USD government, so many of the programs were actually cut short midway. What is it? What is the effect of the same in terms of running health function at the county? And what is it that you're supposed to do moving forward so that even the gains that have been for the last 12 years then are not lost as a result of this cutoff? HRH is always one of the motive issues. So there are so many things that we need to discuss under human resource for health, including the community health promoters, and of course now the implementation of primary health care, where we and the like.